we were going to talk a little bit about selection criteria for kind of intermediate stage hepatocellular carcinoma today. There's obviously a lot of controversy and discussion around those patients who are intermediate BCLC stage B. I don't have any conflict. So we all know that a hepatocellular carcinoma is very common, most common primary tumor, fifth most common cancer, second leading cause of cancer-related deaths with significant geographic variations. And, it accounts for 7% and probably getting to be even higher among all cancers in the world. Actually, I just came from clinic and I just saw a young gentleman in his 40s, actually, but very obese with NASH and NAFLD with a very advanced HCC. So I think, as we continue to have problems with the epidemic of obesity and NASH and NAFLD, we're going to be seeing more and more patients with HCC and even advanced HCC. So the staging system for hepatocellular carcinoma, we love talking about this. The kind of state-of-the-art pathologic staging system is the AJCC, UICC staging system. And you can see that here on the screen. That's been most recently updated in the 8th edition. And this is really a pathologic staging system. It's not really a clinical staging system. Some of these factors can be assessed preoperatively, but in general, AJCC is a pathologic staging system. And patients are classified as either having a T1A or T1B lesion, whether they have a solitary lesion that is either less than 2 centimeters with or without vascular invasion, greater than 2 centimeters without vascular invasion. And then you can see in T2, it's those lesions that have vascular invasions that are multifocal. And then T3 are lesions that are greater than 5 centimeters. Most of us have been focused on or discussed the BCLC staging system. These other staging systems like the JIS, the Japanese integrated staging, the Hong Kong staging, even the CLIP to a lesser degree are frequently discussed as means to stage patients in the preoperative setting, but really most of the time we're talking about BCLC. And the reason for that is multifold, but most large liver associations, so EASL, European Association, and the AASLD, the American Association for Liver Disease, both kind of endorse the BCLC staging system. And what's kind of unique about the BCLC staging system is that it kind of combines not only tumor status factors like the AJCC, which is only tumor-specific factors, but it also incorporates liver function and also health performance status with the ECOG. So it's more kind of holistic in nature. And then also, in addition to being a staging system, it's really a treatment allocation algorithm. And if you look at the BCLC guidelines, and these are 2018, they were just recently updated in 2022, I believe. You can see here that patients are classified into very early stage 0 or early stage A, intermediate stage B, or advanced C and D. And these different stages, whether it's A, B, C, have prognostic implications, but they also have treatment implications, isn't that the BCLC kind of dictates that whatever stage you're in, it should follow what type of treatment should be recommended. And you can see here that traditionally the BCLC has only recommended surgery for either very early stage or early stage HCC. So for those patients either with solitary disease or very small burden of disease, but they have not recommended surgical resection for intermediate stage BCLC-B patients. So there's a lot of discussion and debate around whether resection for these intermediate HCC patients is justified. And if you look at the evidence, you can see a number of papers that have been published on this topic, several of which are from our groups you can see up here in the left upper hand corner and the right lower hand corner, large multi-institutional reports that have reported on recurrence patterns and outcomes after resection of patients who are BCLC-B, and then also reports from other international groups, is Dr. Truzzilli, who's in Italy, and obviously Dr. Makuchi in Japan, and then other groups from Korea. And if you look at the data in aggregate and systematic reviews, and you look at partial hepatectomy versus a TACE, you can see that in many studies that even amongst patients who are BCLC-B, that the data would suggest that there is a subset of patients who can benefit from surgical resection rather than palliative treatment, if you will, with TACE. And if you look at this study from Korea, which looked at BCLC-B patients and compared partial hepatectomy versus TACE, you can see that patients who underwent partial hepatectomy, which is in the kind of purple circles, if you will, have better 1, 3, and 5 year survival compared to patients who were treated with intra-arterial therapy. Now, obviously, the problem with looking at those type of data is that, it's all retrospective, so it has massive selection bias and confounding by indication. And also, if you look at these different studies, there were inconsistencies of how patients defined intermediate HCC. What was the definition of BCLC-B? There were overlapping populations. And then also some patients didn't get just one therapy, but they got multiple therapies, sequential therapies. Maybe they got TACE and then they went on to resection. And it's hard to kind of tease out, if you will, the true differences in these groups. And then really, as surgeons, for us to identify, what is that specific subset of patients with BCLC-B intermediate stage disease who could benefit from surgical resection. So there's a paper that we published in Annals of Surgical Oncology now a couple of years ago. And in it, we looked at patients who were BCLC A1, and versus B. And just to refresh your memory, kind of pictorially, you can see that BCLC 0 is solitary tumor less than 2 centimeters, solitary lesion that's 2 to 5 centimeters, or less than 3 centimeter multinodule disease, 2 or 3 nodules. A1 is solitary greater than 5 or equal to 5 centimeters. And then B is multifocal disease that is either small or multifocal disease that is numbering 4 or more in size. And what was interesting, and perhaps not surprising, is that when you look at 0, A, and A1, there's clearly a stratification with regards to long-term prognosis as stage goes up. However, if you look at patients comparing A1 patients to BCLC-B patients, there actually wasn't too much of a difference in survival, suggesting that it may be somewhat arbitrary that the BCLC is saying it's fine to operate on A stage patients, but not on B stage patients, because perhaps there is a subset of BCLC-B patients who will benefit from survival. And again, that was evidenced by their somewhat similar 5-year overall survival after curative intent resection. And again, if you look at other series besides our own, these are data published from Japan. They've shown that in patients with multinodular disease, the 5-year overall survival can be in the range of about 45%, which is not unreasonable. However, you can see that most patients will recur. 4 in 5 patients will be, if they're alive, they will be alive with disease by 5 years. This is a different study published from Korea that also looked at stage B patients and did a propensity score matching. Propensity score matching is an attempt to compare groups that are more comparable, apples to apples, taking into account all the tumor characteristics, baseline patient characteristics, so to create as comparable groups as possible. It's somewhat flawed still because you can never get rid of all of the bias in a retrospective study, but at least the data would suggest that in some patients who are BCLC-B, look what liver resection, 5 years, they had a 5-year survival rate of 60%. So again, suggesting that there's some intermediate patients who may benefit from surgical resection. This is another paper that we published in Surgery, looking at this idea of possibility of a cure. What's the cure fraction? And we compared patients who were BCLC 0 or A versus BCLC B. And what we found is that for BCLC 0 or A, it was about 47%. And for BCLC B, it was about 38%. So yes, lower in BCLC B, but still about 40% long-term survival in patients who underwent resection. And if you look at the patterns of recurrence in patients who recur within who underwent surgery within BCLC or beyond BCLC, you can still see that the majority of the recurrence in either setting is within the liver, with very little disease failure at the extrahepatic site. So these data would suggest perhaps that if you can extirpate all of the disease in the liver, that these patients can derive a long-term benefit. And if you look at the factors associated with statistical cure, the factors included AFP, as well as tumor size and tumor number. But in the BCLC-B group, it was largely AFP. So these data might suggest that, you know, as we try to figure out who in the BCLC-B group we should operate on, AFP can be very helpful. If their AFP is over 400, you can see here that the cure fraction is very low, 5%, 7%. So I'm less likely to operate on that patient. But if you have a BCLC-B patient that has a low AFP, you know, it seems as if their biology is better, and I'd be much more likely to consider operating on that patient. And indeed, if you look at this study, again published from Japan, they classified patients into 3 different subtypes of categories for BCLC-B, and noted that in those patients who had oligonodular disease that was small in size, that these patients did better than patients who had a larger burden of disease. So, you know, this study is interesting because it suggests that another way to potentially identify patients who may benefit the most from surgical resection is by identifying patients who maybe have a lower overall tumor burden within the liver. And so, you know, you'll see that later on we began to incorporate that into our new tumor burden score. But other groups have kind of come up with this idea of overall tumor burden. I'm sure you're familiar with the up to 7 criteria. So the up to 7 criteria is, you know, adding up the size of the lesions and the number of lesions. And if that's over 7, then those patients have a worse prognosis than patients who have, you know, under 7 when it comes to the number of tumors and size of the tumors. And as I mentioned, this led us to develop this tumor burden score. And, you know, we published a number of papers now using this tumor burden score. And this is a single composite score that uses the Pythagorean theorem to incorporate the number of tumors and the maximum diameter of the tumors that come up with a single score. There's the overall tumor burden in the liver. And it makes sense, right? Instead of like counting up the numbers and counting up the size, like what's a single composite metric that can give you an idea of how much burden is in the liver. And if you look, not surprisingly, in BCLC 0, virtually all the patients have a low tumor burden score, right? And BCLC A, most of the patients either have a low or medium tumor burden score, but you can see that there are some that actually have a high tumor burden score. And in B, there are some that have a high tumor burden score, but there's also a fair number of patients that have a median tumor burden score. So perhaps using tumor burden score rather than just BCLCA stage A versus B alone, we can better identify which patients we should operate on. And in fact, if you look at long-term survival, the tumor burden score does even a better job than the BCLC 0, A, and B staging. You can compare panel A and panel B with regards to overall survival and tumor burden relative to recurrence-free survival. And then if you look at these figures, is what we've done is that we've stratified patients relative to BCLC A and B, relative to the tumor burden score. And what these data demonstrate is that indeed, amongst patients who have BCLC B stage disease, those who have a median tumor burden score do significantly better. And we did this in our multi-institutional data set. We externally validated it. And that's why I think when you're considering patients with intermediate stage disease, I look at the AFP. Like I told you, if it's high, then I'm less likely to operate on those patients. And then I think also if they have a high tumor burden score, I'm less likely to operate on those patients. The patients who are most likely to benefit from following surgery with regards to long-term survival are patients who are BCLC-A with the low tumor burden score, or patients with BCLC-B with the median tumor burden score. You can see here that if you look, there's complete overlap between BCLC-B and BCLC-A if they both have the same tumor burden score. So that's why we think that this tumor burden score is informative and perhaps even more informative than BCLC-B staging. And in this paper that we published in Annals of Surgery, again, it emphasized that the two most important prognostic factors in identifying patients with regards to surgical resection who have multinodular HCC is a preoperative AFP greater than 400 and a high tumor burden score. Those patients have significantly worse long-term outcomes. And here, multinodular HCC, you can see that the risk is completely parallel to the overall tumor burden within the liver. And we validated this in external validation data set. And you can see in those patients at highest risk that they will recur, 60% will recur within 12 months, compared to only about 20% for patients who have a low risk, and low risk being low AFP, low tumor burden score. So more recently, we've used machine learning to help us identify which candidates may be the best to select for resection who are beyond the BCLC criteria. And as you know, machine learning is a powerful tool in which we can use either supervised learning or unsupervised learning to iteratively look at the data, informed by clinical information, but not biased by human input, to help identify different nodes within the machine learning algorithm that are prognostically important. And in this cart, so this regression tree, what we find is that in people who present with HCC, the first thing that's important is whether they're BCLC 0 or A versus B. But among patients who are BCLC 0 or A, the next thing that's prognostically important is the AFP level. And then amongst patients who have a low AFP level, what's most important is their baseline performance status. So it makes sense, right? Good biology matters first. If you have a high AFP, that's going to drive your prognosis. If you have a good AFP, what drives your prognosis is your performance status, whether you're healthy to begin with. Over on the BCLC-B side, what's most important, as I mentioned, is this tumor burden score. And actually, the tumor burden score can be assessed preoperatively based on radiographic imaging. And if you have a tumor burden score that's over 8, then you can see here that your 5-year survival is only in the range of about 25%. That's why these data can be helpful in the preoperative setting to identify which patients may benefit from surgery. And then in the post-operative setting, we similarly did a machine learning analysis. And in the post-operative setting, once you have the pathology back, lymphovascular invasion is the most important factor for patients who are BCLC 0 or A, but tumor burden score, now based on actual pathology, is what drives patients' long-term survival. And in fact, if you have a tumor burden score greater than 11 on your final pathology, your 5-year survival is only in the range of about 10 to 15%. So, we frequently talk about this intermediate stage, disease, and that these patients shouldn't be offered an operation. But I think it's really much more complex. This is a very heterogeneous group of patients that have hopefully demonstrated that things like AFP and tumor burden score can help us tease apart some of the heterogeneity in this area, and identify those patients who may be best candidates for surgical resection. So I think, and hopefully you agree, that designation into the BCLC stage B shouldn't be considered an a priori or absolute contraindication to surgery for patients with resectable tumors. If resection is feasible, then patients should be considered for surgery, especially if they have AFP levels less than 400 and their overall tumor burden score is moderate to low. I think in the future also, now with immunotherapy and targeted therapy for hepatocellular carcinoma, more and more we'll be treating these patients in a neoadjuvant approach with Tazo-Bev and other things to test their biology of these patients and downsize their tumors, and then taken to the operating room following preoperative systemic chemotherapy. So with that, I'll conclude and be happy and eager to engage in discussions with all of you. And again, I really appreciate the opportunity to be with you virtually, and hopefully one day I will be there in person.
Maybe next year.
Yeah, that'd be great.
I have a question. How do you assess tumor burden post-operatively? I mean, in the pathology.
Yeah. So basically, it's done the same way. So after they report out the number of tumors in the pathology report, and they report out the size of the tumors in the pathology report, it's just, you can just simply calculate it. In our group and other, our group is put online like automatic calculator. You go like into what's called a Shiny app, and just put the numbers in, and then no problem, you could calculate it.
Okay. So let's see if we have any questions from the audience. Please, if you have a question, raise your hand. Dr. Madhat Khafagi.
Thank you, Dr. Pawlik. How often do you do liver transplantation in such intermediate cases?
Yeah, so that's a good question. So usually transplantation in general is, relegated to patients who are earlier stage, right, within Milan criteria. But that being said, there is more and more interest of trying to downstage people who have larger tumors, right? Obviously the UCS criteria. But I do think that with targeted therapy and immunotherapy and some of the responses that we are seeing, that perhaps in the future, there will be even more a role for transplantation of patients who have been downsized and have demonstrated good biology after having been treated with neoadjuvant therapy. I mean, at our center right now, we do about 140 liver transplants a year, but the majority of those aren't for HCC. Most of those are for, cirrhosis, steatosis, other causes.
Okay. Any other questions? Please, if you have a question, raise your hand. Dr. Madhat, do you have another question?
Let me think.
Take your time.
Is there a difference in doing clamping of the portal triad during resection as regards the ischemia time from normal level or cirrhotic level?
Yeah, I mean, I think so. I mean, I'm pretty liberal with the Pringle maneuver on a normal liver. You know, if I think if it's needed or warranted. I don't routinely use a Pringle maneuver, but now with more kind of non-anatomic resections, especially for colorectal liver metastases, you know, sometimes those can even be a little bit bloodier than an anatomic resection, right, where you're taking the pedicle. I will use a Pringle maneuver. But I think for patients who have a cirrhotic liver, you know, I really try to minimize the ischemic insult to that liver. So yes, I think there is a difference.
Okay. Any other questions from the audience? Please raise your hand if you have any question. Okay, I think that was it.
All right, great. Well, hopefully
Thank
that
you.
helped and that was interesting. I always enjoy joining all of you. And like I said, maybe next year I can visit you in Egypt. It would be an honor and a pleasure.
Hopefully, I'll try to check out the conference dates early. So
Okay, great.
you know.
That
Look,
sounds good. All right, my friends, stay well.
Thank you.
All right,
Thank you.
bye-bye.
Have a
Thank
good
you.
night, everyone.
Stay well. Yeah, good night.
Yeah.
Bye.
Bye-bye.